Dr. David Levine. Today is April 9th, 2022. I'm in San Diego at the American Association of Plastic Surgeons meeting, and I'm here to interview icons in our society. The concept of these interviews is to preserve in an audio-visual fashion icons of our societies, pioneers, forward thinkers, inventive personalities, and teachers. And the purpose of this is just so that when future generations want to know about it, who was this person or what did they do, they can look this up. The American Association of Plastic Surgeons sponsors this, and I'm pleased to be here with Dr. Michael Bentz, who is a professor of plastic surgery at the University of Wisconsin. Dr. Bentz, thank you.
Glad to be here today.
Okay, great. And would you state your full name, date of birth, and the name of your parents and wife and children and grandchildren, just so we can,
Absolutely.
Cover that.
Michael Lloyd Bentz. I was born in Pittsburgh, Pennsylvania in May 9th, 1958. I married Kim Livingstone Bentz in 1988. We have 3 children, Gretchen, Alex, and Eric. My father was Joe Denton Bentz from York, Pennsylvania, and my mother was Ida Troxel from Altoona, Pennsylvania.
So you're a Pennsylvania guy.
I was till 22 years ago.
Right. Everything else, you did your medical education. Was it at
Temple.
Temple, okay.
Went to Temple Medical School, and then I stayed at Temple for general surgery residency. Mm-hmm. Then went to University of Pittsburgh to do a microsurgical research fellowship, and then stayed on for the plastic surgery clinical residency. My anticipation was to go back to Philadelphia and work with my pediatric plastic surgery mentor there, but I ended up staying on faculty at University of Pittsburgh as an assistant professor and then associate professor. And
your interest, among other things, first of all, I asked you earlier how many residents you've trained. And
trained just over 100 residents between the University of Pittsburgh and University of Wisconsin.
And the number that have gone into academia?
It's about 65% of them.
That's amazing. Okay. The question of plastic surgery, I read a little bit of your autobiography. Your dad is a doctor, right?
He is.
Okay, is. He's still alive?
Well, he was.
Okay, yes. Okay. And what kind of physician was he?
He was very different than I was or am. He was an expert in industrial occupational medicine. Okay. He was one of the co-founders of the American Board of Occupational Medicine. He was the medical director at United States Steel, which is how I ended up growing up in Pittsburgh, actually, before returning for fellowship residency in my first faculty position.
And I believe, was your mother a nurse?
My mother was a nurse, and that's how they met.
Okay, wonderful. All right. So a couple of things that I'd like to get into is your interest in craniofacial surgery, and a little bit about your relationship with Dr. Ian Jackson, who sadly passed away this past year. But would you mind saying a few things about your experience there and thoughts?
Yep. When I was rotating as a resident through pediatric and craniofacial surgery, I was really intrigued by skeletal craniofacial surgery, but really was passionate about general pediatric plastic surgery. So clefts, trunk reconstruction, extremity reconstruction, and particularly congenital hand reconstruction. So I focused on that, and there were several of us at the time that had that interest. Up to that point, being a pediatric plastic surgeon pretty much meant you had to be a skeletal craniofacial surgeon. Okay. And while I appreciate the difficulties and the challenges of that, it just wasn't what I was passionate about. So I've focused my clinical practice time on general pediatric plastic surgery and extremity reconstruction.
Did you have a facial malformation clinic at Wisconsin?
We have a craniofacial clinic, a cleft lip clinic, and we have a multidisciplinary also birthmark and vascular anomalies clinic.
Wonderful. Okay. Yeah, I was lucky I went to a program that had a craniofacial clinic too. It was wonderful. Because they're just, if you're in the Pennsylvania, Ohio area, you see a lot more. If anybody doesn't know, there are a lot of Amish families, and they tend to have, I think, a higher incidence. Would you agree with that?
They do.
Yeah.
In multidisciplinary cleft and craniofacial care is really now the standard, with plastic surgery leading most of those teams.
Okay. Now, we've seen, and you've seen momentous changes in plastic surgery during your illustrious career. Could you just talk a little bit about them?
Sure. It was interesting. We had this conversation in the operating room this week with the residents. They wanted to know the first day I took surgical call, and that was July 1st, 1984. And while that seems like an incredibly long period of time ago, I can tell you exactly kind of what happened that night. But so I think within plastic surgery, during that time, microsurgery has evolved. Various techniques have evolved. Now microsurgery is a tool that every plastic surgeon is trained in and is capable of doing in their practice, should that fit their appropriate practice demographic. We have replaced procedures that we used to do in the 80s, 90s, with new procedures now with better efficacy and safety. And it's why I stress to our residents, we try to teach principles and not operations, because operations go away, but principles will stand the test of time. I think we're at a really interesting time now in plastic surgery and medicine in general, evolving cell-based therapies and also kind of generating genetic understanding and potentially the opportunity for genetic interventions earlier than what we're capable of doing now.
And when you say cell-based, you can qualify a little bit more. Are you talking about stem cells and organ growth, or?
So I think it's the primary evidence of that would be fat grafting for various reconstructive options that has a stem cell component to it. Now what we need to do is harvest these pluripotential stem cells that don't have a lineage defined when we need to grow muscle, bone, mesenchymal tissue, soft tissue, skin in ways we can't now. And I think it's going to simplify reconstruction moving forward. So we're not doing what we do now commonly, is taking a body part and transferring it microsurgically or otherwise to an area of need. And I think it's going to be great for patients. I think it will also be a time saver for physicians. We will be able to more directly treat patient reconstructive challenges.
And that's part of the purpose of the ICON project, is we're having a conversation on April 9th, 2022. 50 years from now, this conversation will feed into whatever plastic surgery is and the advancements we've made. Because as you know, first breast reconstructions were done in the early 70s, and how far have they advanced?
Tremendously.
And, so that's part of the purpose of these discussions that we're having.
Given the pace of change, I hope in 15 years, this part of the discussion today seems antiquated.
It probably will be. And we've kind of covered this, because one of my questions was, what do you feel the most important innovation in our specialty is? Would you say microsurgery?
So I think the reflex response would be a clinical theme, and probably microsurgery's had the biggest impact. I actually think probably the changes in our educational process will have even more downstream dividends in terms of how we're training plastic surgeons, the quality and uniformity of the quality of plastic surgery training, and the product of plastic surgery residencies and fellowships, which I think is tremendously elevating all types of plastic surgery care, from cosmetic to reconstructive.
Now, at the University of Wisconsin, it's 2 or 3 year residency.
We're 6-year residency.
Combined.
And then we have a year research fellowship in the middle. So for some people, it's 7 years. And that model, which is different than many of the icons trained, where we trained in general surgery first and then trained in plastic surgery. Well, I think we all had some element of discomfort with it at the beginning. We've now seen the product, whether it's clinical or even board outcomes, is superior to a traditional, at least independent residency program.
And you've been a board examiner, correct?
I've been a board examiner, chair of the board, ran the oral exam. That process has been really important to me, following my own experiences with the exam process when I was a candidate.
Well, I have to tell you that the probably greatest trepidation that a practicing plastic surgeon has going into his oral boards. It's a everybody's sitting around. I don't want that examiner. I want that examiner. Everybody has the same level of trepidation, is the word I'm looking for.
There is no question that is a high stakes couple days for the candidates, and we have worked hard in a series of oral exam chairs to create a standard exam environment that, while is rigorous, because that's what the public needs, is fair and reproducible. And I think we're getting closer and closer every year to refining that process.
I was going to ask you, what do you feel is your greatest professional accomplishment?
No question, my residents.
Wonderful.
My impact as a person is limited. The impact of my residents going out and on their residents is the big multiplier. So there's no question, there's nothing at work I'm more proud of than my resident graduates.
As a specialty, what do you feel our greatest mistake has been?
I don't know if I would label it exactly mistake, but I think we have been somewhat late to work collegially and collaboratively with what not that long ago would have been perceived to be our competitors in facial plastic surgery and oculoplastic surgery, because in general, they're well trained and they are good at what they do. And at our location, we all work wonderfully together. It's the practitioners who aren't trained appropriately for primary delivery of plastic surgery, and particularly managing plastic surgery complications, who haven't been through the rigors of training that the ABMS board trained either plastic surgeons, us, or our facial plastic surgery colleagues or oculoplastic surgeons have, that I think that it will be important for us to continue to work collaboratively to protect patients from this group of practitioners out there that is perhaps financially motivated but not appropriately trained to perform these procedures.
And I agree. You and I know the turf battles that occurred early on with, quote, cosmetic surgeons, and to differentiate ourselves from that. And now we're at the point where I agree, we're a little more collaborative, because the enemy of my enemy is my friend. And we have people out there, as you know, doing procedures that they shouldn't. I'm always amazed. Oh. The guts, I could use another word, that they have to do things. I'm thinking, this is not that easy. It's not a 2-week course, what we do. It's a lifetime.
That's so true. And I hope that the House of Plastic Surgery, between the artificial divisions of reconstructive and aesthetic surgery, continue to work closer together, and then we bring in our oculoplastic and facial plastic surgery colleagues to really work towards optimal patient care.
Who do you admire most professionally? Alive or
so I would say I had several early mentors that led me to do what I do. My first was my general surgery chair, Wallace Parks Ritchie at Temple, who unfortunately just passed away last week. And he showed me what the joys of academic surgery were. The chair of surgery that recruited me to Wisconsin, Bing Rickers, is one of the most amazing leaders in academic plastic surgery history, president of the American Surgical Association, and a phenomenal human being, and showed me that you can be a strong academic leader and yet have high emotional intelligence. But my primary mentor is Bill Futrell, my chief at Pittsburgh, who has been an incredible friend, technical mentor, introduced me to global surgery, and someone I talk to virtually weekly now.
Glad you mentioned that. Global surgery. Define what that is. I think I know, but when you refer to global surgery, what are you referring to?
So specifically to plastic surgery, it's the delivery of plastic surgery care in environments that are predominantly developing countries, where either educational background and training or materials are not present. So our division at Wisconsin has a long tradition of being committed to overseas education and capacity building, starting in 1991 by Dr. DeBell and Dr. John Noon. When I arrived, having had experience and passion about that interest, we built out our programs at Wisconsin. I just finished a $3 million funding round for a distinguished chair. And so we have educational projects and relationships in Thailand, Vietnam, Ecuador, Nicaragua, Ethiopia, and Egypt. And these are based on capacity building and education. The clinical care we provide is the vehicle for education. While people say you must feel great about that, I feel good about it, but the relationships and the friendships we build are important. And again, the multiplier is helping someone who needs some additional education perhaps, or some materials. We've taken operating microscope down to one site, taken it apart, put it back together so that they could deliver care the 50 weeks of the year that we're not there. And so it really is trying goal of education to change patient lives in other places where the patients might not otherwise get their care.
Is there a specific name for that program? Are you part of another program, or is it unique to the University of Wisconsin?
We had a private foundation called EduPlast, but we've kind of dissolved that and rolled that into the university. It's our division-based program that involves some private practitioner plastic surgeons in town, as well as many of our alumni.
I assume you take residents with you when you go and on these medical trips, yes or no?
We do. We also sponsor a residency program in Nicaragua where we pay the resident salary there because there's no graduate medical education funding availability there. And so the interaction with the residents to the residents, I scrub with our international colleagues, our residents cross scrub. It becomes really a learning situation. And I would say our residents and our faculty, which is not surprising, come back from those trips and feel like they've taken home more than they've left.
Yeah.
So it's a goal to continue to keep delivering and working with our partners and friends.
That's wonderful. Great. Okay, I'd like some words of wisdom from you for present and future generations of plastic surgeons.
So practically, based on work and home, the topic of my presidential address in 2016 for the association was basically work-life balance. It was entitled a little differently, but so I do think that we need to pay more attention to how we balance what we're doing both at work and home. I don't know that balance is even the right word. Probably integration is a better word, but I think we can probably do more moving forward with our families than we have historically done. I think that from a surgeon health point of view, surgeons need to look after themselves a little better than historically they have, particularly plastic surgeons ergonomically, who historically have ended up with, and I've had a couple neck procedures and things that taken care of kids for a long time, but if I had paid attention to that and was attentive to some of the things you can do in the operating room to protect your own health, that provides longevity both for work but also for your family.
Yeah.
And then for whether it's surgeons, applicants, residents, I think the key thing, given how difficult this life can be at work, hours, stresses, the burden of complex reconstruction, I think that everybody has to find out what they're really passionate about and pursue that and not look back. And there's so many opportunities in plastic surgery to deliver high level care, education, research. I think everybody has to, doctor, know thyself and figure out what you're passionate about, because I think you're going to go the distance more likely if you're pursuing the things that is consistent with your passion.
Okay. You mentioned earlier when you were talking, I thought about a great quote, which was kind of what you'd said, but in plastic surgery, I wish I could say it's my quote, but learn principles, not methods. The mind that grasps principles will devise its own methods. And that's what I love about plastic surgery. It's a creative field. When you do reconstructive anything of any type, which is why I love our profession, because it's constantly changing both with technology and just the fact that, hey, let's try this out. We have to go beyond the edge sometimes to develop what we've got. And you mentioned earlier about microsurgery, and the first procedures were just tough and under a microscope and getting used to it. Now they've moved along where they have the little stents and everything, but I thought about that when you were talking about the principles about learning plastic surgery.
It's so true. I mean, we are so fortunate to do what we do. I gave a talk on campus 2 weeks ago to the undergrad pre-med society, and they had a kind of an interview format. And so the president said, "So what do you do?" And I said, "I deliver hope."
Yeah.
And everybody's eyes rolled. I could tell that they didn't get it. And then I showed a bunch of cases, and at the end, people were like, okay, I get it now. I mean, I understand the anatomic fun and challenges of it, but this makes a difference for patients. So we're really lucky.
Okay, one question I've added on because of our COVID lag is how did that affect your life? Maybe positive in some sense, maybe negative. How with your residency, how that was incorporated, because it changed the complete dynamic of this country. And for those that some generation, the COVID infection is a worldwide infection that affected and resulted in millions and millions of deaths, and basically made us housebound and hunkering down for a year. So how did that affect you in the residency?
Oh, it affected everything. So I was one of the first people to get COVID at my health system, kind of long before it was clear what you had to do and how long you had to be out. And I felt pretty well, had a little tachycardia, but you didn't know what we were dealing with, and you don't know if you're going to wake up the next morning. And it was interesting. But going back to that, then we set up systems to protect our residents and our faculty. We developed some pods. Those of us with general surgery training volunteered to take ICU coverage and call to help out with the ICU burden that was up front. I had obviously moved to a virtual learning system, but we've been broadcasting our grand rounds live for, I think, 17 years now, long before we needed to, because that's how we interact weekly with our international partners, is through Wednesday morning grand rounds, live webcasted. So that was an easy flip for us. We did have to develop some systems around care, but then try to sort out on the back end how to make sure the resident experience did not get impaired by the process. In other words, making sure that if a certain rotation a resident get, we're able to double back and get that experience for them as we opened up again in the first wave and then closed down somewhat in then the second wave. Obviously, our nuances of our response were better clinically, so I think that their second round impacted the residents less. The first round was not insignificant, but at least we were able to propel the educational program forward, including to our international partners. And that was, I think, kept us together as a group and maintained the connections that are so important that Bill Futrell, my primary mentor, taught me in terms of the relationships we have, whether they're work, home, and the two of those, and maintaining those for our residents and our graduates.
Okay, let me just check out a few things here, and I appreciate that input. Okay, good. See, I've covered everything pretty well. Any thoughts you have or want to talk about anything else that we haven't covered?
It's been fun to watch the association change in the time that I've been involved. Back when I was initially serving on the issues committee, and then was asked to chair it by Paul Manson, then president, and I asked Dr. Manson, what's the committee charge? And he kind of gave me a carte blanche. Take a look at the association and figure out, what we should do, where we should go. And so we started gathering some data from members in what was, I think, maybe perhaps a little controversial survey in which I presented one of the business meetings. But what it showed, that people loved the association, that it seemed to predominantly represent academic plastic surgery, but maybe not inclusive in a diversity, equity, and inclusivity way, nor even across the spectrum of plastic surgery practitioners. So it's been fun to watch officer groups over the years continue to, I'll say, modernize the association to what it is now, and I think that's why it's such a strong organization.
Well, I have to tell you, when I was a senior resident at Akron City, the trip to the association meeting was a highlight. And I have to tell you Ralph Millard's story. He was quite the man. I wish I'd gotten a chance to interview him. But another doctor, who I won't mention, had presented a case of using a rib graft to repair a hernia. And we were sitting there as residents, and we're like, we're going to be practicing physicians in less than a year. We're there listening to these academicians, and the doctor presented this case of using a rib graft for hernia repair. He was the chief of a program, no names mentioned, and Ralph Millard got up. I'll never forget it. He said, "Thank you, Dr. So-and-so, Dr. X, for that interesting presentation. I'd like to say to all you second-year residents out there going into practice, never do this procedure." And there was a hush, everybody, and that was the end of that. But it was a highlight to get around other residents and to go to this and watch. I mean, these are the academicians that are responsible for what we have, and that's the purpose of this ICON project. Part of it is to preserve that.
I usually have at least a resident in tow, and when they go to the opening reception tomorrow and their jaw is down, like there's so-and-so who wrote this or published that or created that. It's an awesome, incredible group of people, innovators, surgeons. It's still, I look around and I just feel privileged to, being part of it at all. When I was an assistant professor, I would have not even known I'd be a member, much less have a chance to be the president.
Well, that's why you're an icon.
Not feeling like an icon, but appreciate.
Well, you've all the category, all the boxes are checked as far as I'm concerned. And by the way, I was going to ask you about advice for retirement, but you look like you're many years from retirement. So,
not retirement, but what I've seen actually in surgeons who have retired well is that they had a plan, and it was a stepwise withdrawal of different activities along the way. I think the people who retire cold seem to struggle more. This is our identity in many ways. And actually, I hope the next generation that's not entirely true. But I think that for the next round in my generation, I think a plan, no different than a complex operative case, will get people through it.
I agree.
More successfully.
I retired, and I won't say I had an exact plan, but I essentially have gotten to do all the things I always wanted to do. I don't sleep late. I said, when I retire, I'm going to sleep late. Now I get up early in the morning. Now I run out of gas for about 1 or 2 o'clock and have to take my nap. But I love what I did in plastic surgery, and I still have a relationship with the other plastic surgeons in town and go to the meetings and obviously come here for this. So for me, it's been a blessing. And it's been a privilege to interview you, sir. Thank you so much.
It's been fun. Thanks so much.
Okay. We'll see you later.
Appreciate it.
Thank you.